Welcome all. And for the second part of the role of cardiac markers in diagnosis of heart diseases, in the first part, we have gone through the basics of cardiac markers. So, what are the cardiac markers, how they are actually used, and when time the cardiac markers are released at what time. So, all the basic things. Now, the part 2 cardiac marker will be more going for a clinical aspect. That what are the diseases which can be diagnosed with the cardiac markers? What are the shortcomings? When the role of lab decreases and a point of care role increases, all of this will be covered in the second and final part. So, if I talk about the main reason of visiting emergency department, as you see, there are 5 leading reasons to approach to a emergency. So, the first and the topmost leading cause is shortness of breath and sometimes chest pain, which is nothing but the acute coronary syndrome. Second comes neurological fever. In chest pain also is one of the reason. Abdominal pain is one of the reason. But principal out of 5 emergencies, 2 are cardiac related. The shortness of breath and chest pain, which are the very common 2 reasons of a person reaching to emergency for treatment. So therefore, you can understand how much important is to know about these cardiac markers. So the cardiac markers, the features must be, cardiac markers must be the thing which is located in the myocardial tissue and released in case of a cardiac injury. Say that may be myocardial infarction, that may be non-curable infarction, maybe unstable angina or other things like trauma, cardiac surgery or whatsoever. But the major and the basic criteria is that has to be a thing marker which is located in the myocardium. When myocardium damages, it releases its markers. As I have already told in the last previous one, these are the most ideal characteristics of cardiac markers. These are high sensitivity, specificity, clinical characteristics, and analytical character. Already I have dealt in my previous lecture, so that is I am not going with. Now with the acute coronary syndrome, there are 3 kinds of acute coronary syndrome. One is a chest pain, but there is no infarction, there is no heart attack called commonly. So they are called angina. Then it's unstable angina. Angina is what when somebody is working high or there is any stress which leads to angina. Unstable angina sometimes happens without any provocation. And last is myocardial infarction, that was a heart attack when the heart does not get the blood supply or oxygen supply and therefore it dies because of that. So it is myocardial infarction is the most fatal part of the acute coronary syndrome. So these are the common risk factors. I think everybody counts. Out of these 9 risk factors, you will always encountered 5 or 4 is with you when you are a middle-aged person. Like age, gender, family history, hyperlipidemia, smoking, hypertension, diabetes, obesity or high plasma homocysteine levels. These are the very high risk factors for ACS. Now the criteria of diagnosis of an acute coronary syndrome is, it's called a triad criteria. Triad criteria means 1, that severe and prolonged chest pain may be atypical. Sometimes it comes not only, sometimes you may feel pain in the shoulder, may feel pain in the epigastrium, or sometimes most definite difficult thing is that particularly if you are a diabetic patient or neuropathy patient, you may have a silent angina. There is no pain at all, but the heart attack has happened. Then ECG changes and last cardiac markers. So the triad of criteria is out of these 3, the clinical scenario, the blood markers and ECG, any 2 of the 3 has to be positive to diagnose it to be an ACS. So therefore, although this criteria is now changing with advanced cardiac markers, that is we are going to talk about. So you know the pathophysiology of acute coronary syndrome, you know that you can see the vessel is narrowed by the atherosclerotic plaque, and at time when the atherosclerotic plaque ruptures and creates a clot and the blood vessel is unable to deliver supply to the myocardium. And I have shown in the picture, you can see on the heart there is a dark colored circle. That means that area was supplied by that artery which got blocked, and therefore the tissue will die on that area which actually getting supplied by the artery. So that is the myocardial infarction. These are the things how it happens. Initially it forms a plaque, and therefore it becomes, you see the flakes are formed here, so it increases sometimes and it narrows down. So when the lumen gets narrowed, so less amount of blood and oxygen goes, and heart tissue gets less and less oxygen and nutrition. So sometimes there is chest pain happens. But this is the dangerous thing. When the plaque ruptures and there is a blood clot appears, it actually blocks the whole lumen. So there is no supply, and therefore it can lead to a myocardial infarction, which can lead to even sudden death. So therefore, this is the thing as a whole. If you see the cross-section of the coronary artery, it looks like that. Now we come to the biochemical markers. As we have already discussed about the previous one, this is CKMB, cardiac troponin, and myoglobin also. And the traditional one, which we have already discussed previously. Now we will be discussing about the future markers like ischemic modified albumin, glycogen phosphorylase BB, fatty acid binding protein. These are the markers of the future, which is coming. Not yet it is a fully grown marker. Now we will be talking about those advanced markers, because in previous of my episode I have already gone through the previous markers. So first about talking about myoglobin. This is one of the very earliest marker of the chest pain. So as you know, I have shown you that it mainly present in cytoplasm, so it comes out in the blood first. So it releases within 1 hour of the myocardial infarction. So that is a most predictor and a negative rule out factors of this myoglobin, that if myoglobin concentration remains within reference range even 8 hours after the onset of chest pain, you be sure that is not an MI. That chest pain is not MI. Because if there is an infarction, myoglobin has to rise within 1 hour or 1 or 2 hours. The major disadvantage of this myoglobin is it is present in skeletal muscle also. So there is not some specific thing about myocardium. So even in a skeletal muscle injury, the same myoglobin can come out in the blood. So therefore it lacks specificity, but it's a very sensitive one. One of the earliest marker to get rise in the blood. HSCRP is not a marker of MI. It is more of a predictive marker. So CRP more than 6 we consider as a marker of inflammation. But we see this myocardial infarction is basically microinflammation. So between 1 to 6, there are categories you have categorized which actually predicts the development of this myocardial infarction. So when CRP level less than 1, very low risk. If it is 1 to 3, moderate. But if it is 3 to 6, it gives a high risk of development of acute coronary syndrome in future. So it's a more of a predictive marker than a cardiac marker. The recent one, very recently has come up, is a ischemia modified albumin. Whenever there is an ischemia injury has happened, the free radicals are attacking on albumin and alters it. So the albumin, with the advent of ischemic tissue free radicals, they develop an ischemic modified albumin, which actually rises very rapidly within 2 to 4 hours of the ischemia, and also return to baseline by 6 hours. So that is one of the very fast marker, but it again the same thing. It is a negative predictor, and it has got less specificity obviously, because it can happen with stroke, it can happen with hepatic cirrhosis. There are other features which also can develop an ischemic modified albumin. But IMA is a marker when you suspect there is a cardiac injury, and 2 to 4 hours, a very early marker to start with. Another one is glycogen phosphorylase BB. This is an enzyme which is glycolytic enzyme, which plays a role in carbohydrate metabolism, but it has got 3 subclassifications or isoenzymes. GPLL, which is present in liver, GPMM in case of muscle, and GPBB that is present in brain but also in myocardium. So this GPBB fraction that can also rise about within 1 to 4 hours, and peak levels are achieved much earlier than cardiac troponin or CKM. But again, here also it is not so specific and it is yet to develop as a marker, nor has come commercially in our diagnostic field. Then cardiac myosin light chain, it is also just like troponin but doesn't have a much significance. So it is not been, I don't think this will come up later on as a very good marker as on. Lipoprotein phospholipase A2 or LPPLA2. This is also like HSCRP, is basically a predictive marker. This is not a marker of MI. It can predict the development of MI in cardiac in time. So these are all the advanced markers which actually you know just for your knowledge. Many of them are like HSCRP is still in the market, myoglobin is in the market, but others are not yet very regularly used in diagnostic field. So next we come to the most important session, which is more of a clinical outcome. This is POCT of cardiac markers. So what is POCT? POCT is point of care testing. Means the testing is happening in the war zone. Testing is happening on the bedside nearest to the patient, so that the minimum time is taken for a test to do and maximum time you can have at your hand to act. So for that, these are the certain things important. Importance of whole blood platform is very easy because it is difficult, time consuming to make a serum or plasma from the blood. So if it is done in the whole blood, that is the best. It may be quantitative or qualitative assay, although majority of POCTs are now coming with a quantitative assay. Can significantly reduce the assay error turnaround time. That means you get maximum time for treatment. You don't have to wait for a result because time is, you say time is money in case of business, but we call time is life, particularly when you are dealing with cardiac patients. Precision and sensitivity less than laboratory. Yes, we know. We cannot have that much of correctness in a point of care testing what we achieve in the laboratory. But still, there are certain times where slight inaccuracy is also okay, but time delay cannot be okay. So this is one of the things of cardiac markers. That is why we are shifting more towards diagnosis in the point of care testing format. So you see, what do physicians need in an emergency department? They need a result which they can more or less rely upon, and that result has to be very fast. The result has to be very quick because they will get more time for the diagnosis and startup management when the diagnosis is something like EMA. But laboratory use needs ease of use, the robustness, cost effectiveness, and of course traceability. You cannot have a non-valid method to work on or test on. So this is what a physician's requirement and this is a lab requirement. So point of care testing somehow tries to manage both the requirements to become a particular useful tool for the treatment. Now, traditional ways of diagnosis have limitations. What? Many inconclusive results. Sometimes the labs are not available 24/7. It may be a long turnaround time, maybe expensive, maybe risk for patients of what? Misdiagnosis, wrong treatment, fatal outcomes, or sometimes unnecessary cost. So what is that? I'll explain later on here. Now, biomarkers, what we use in emergency care. So emergency care usually have two sections we divide. One is a cardiac section, one is a respiratory section. So cardiac section we mostly come across two major things. One, heart failure. One is acute coronary syndrome or something like MI. So we have two cardinal markers for this. For heart failure, we have NT-proBNP I have already discussed last slide. And ACS is the troponins, cardiac troponin T or I. We prefer cardiac troponin I over troponin T. And for respiratory also, if their person came with a shortness of breath, if you are suspecting infection, the diagnosis which can help is procalcitonin. If you are suspecting something like pulmonary embolism or something, particularly in COVID times, we used to depend a lot on D-dimer. So these are the biomarkers which are the most tool for the emergency care to start, whether it is a cardiac problem, whether it is a lung problem. Troponin again is not a marker of myocardial infarction always, because it can come with several things: malignant hypertension, heart failure, tachycardia, sometimes stroke patients, sometimes aortic dissection also these can rise. So there are certain areas where troponin is not always been a cardiac marker but yes, cardiac troponin is the specific. I've already discussed about it. Now regarding this acute coronary syndrome or myocardial infarction, there I said there were three things. One is chest pain or symptoms. The second one is ECG findings. Third one is the biomarkers. But the major problem is that the chest pain is a vague thing. You cannot always detect on the clinical sign. And ECG, that is the major crux of the story. ECG, the ST elevation is the cardinal feature of the myocardial infarction. I'm coming on the ECG pictures later. But ST elevation is a cardinal feature of myocardial infarction. But 60 to 80% of the myocardial infarction without ST elevation is a very common thing. So it is called non-STEMI, non-ST elevated myocardial infarction. So very frequently we'll come with these terms, STEMI and non-STEMI. So STEMI means ST elevated myocardial infarction. That means the ECG shows the ST elevation, so diagnosis is pretty easy. But when there is an NSTEMI, the entire diagnosis is very much dependent on the cardiac markers. So the challenge of early AMI diagnostics is why this is so important to diagnose it early, proper. Because if you know that we call it time is money. So basically here the time is life. So the challenge is that in case you do a late diagnosis of MI, that can cost life of a person, because that golden time period of 4 hours, that when the heart muscle is still alive, if the reperfusion is managed, then the heart can be regenerated, which is the main challenge here. But what happens if you rule out late? Means you negate the assess, then there is no AMI. So that happens, a patient will be unnecessarily admitted in the hospital, the cost will rise and patient anxiety will also be very high on during those days. So nowadays, what the basic thing of diagnosis, ACS diagnosis, the first thing is severe chest pain and discomfort and anything that is a clinical sign, along with an ECG and then the biomarkers. In between there comes a feature is coronary angiogram. So the coronary angiography is actually the gold standard method of the diagnosis, but it is very difficult. Only maybe 0.1% of the total hospital setup in India have this facility that within 1 hour or 2 hours you can do this angiography. So till the majority bulk of the hospital manages with these three triads: the clinical sign, the ECG and biomarkers, so that early diagnosis and treatment may carry on when angiography may be done for confirmation later. Although with advent of newer technologies, coronary angiography is going to be gold standard very soon, but still it cannot replace the cardiac markers or ECG, because that will be done immediately when you step inside the emergency department. Now, acute myocardial infarction, this challenge lies with this non-ST elevation MI. So their clinical signs sometimes becomes very vague. So if the ECG doesn't support you, as I am showing you, see, this is called ST elevation. So ST segment is elevated, then you are pretty sure there is an MI. But sometimes, the majority times, the ST segment does not get elevated, and that is around 60 to 65% cases. ST elevation will not be there. So the major decision-making part is your biomarkers, that is the cardiac troponins. So that is very important, because a clinical sign is a non-specific sign. ECG, And again, I am elaborating it. You see, the ECG with a STEMI and a biosensors, biomarkers together can give a perfect diagnosis. But sometimes there is a atypical things. With ST depression may be there. Sometimes a Q wave is to some extent a problem in Q waves, but no ST segment elevation. So then the major and the most dependent thing is your biomarker on which you depend on. So, where the high sensitivity story begins. Now, we had discussed in our previous slide of the previous part 1 of this cardiac troponin. When the troponin becomes cardiac specific, then it becomes cardiac troponin, and then they become the mainstay of the diagnosis. But nowadays, you are seeing that it takes about 4 hours to get noticed as a as a biomarker which is getting high. So you are going to actually step in after 4 hours. By this time, the golden period of the heart is gone. So here lies the thing that the same troponins can be detected right from the beginning when it starts getting rise after cardiac injury. So what you need to do, you have to make the things, or you have to design it such a thing so that high sensitive troponins can be detected. So this is not anything different. Since microalbumin and albumin is no different, it's just a misnomer because microalbumin reduces very micro amount in urine. Similarly, high sensitive troponin is no different molecule. It is troponin only. We detect it early. So before that, why you are stressing on this troponin so much? Because there is troponin T versus cardiac troponin I analysis, where cardiac troponin T has got some bigger advantages. But for CKD patients, this cardiac troponin T is not that reliable. And that is why all the things are coming around with the cardiac troponin I. That is the molecule is most trusted nowadays. So why they are superior to other markers? Because of the amount that present in myocyte. So more the amount present in myocyte, it will be more sensitive, because with the slightest injury in the cardiac muscles, the maximum will be detectable range release will be those who have a higher amount in the cardiac muscle. CKMB, which is there about 1.4 milligram per gram of weight of this cardiac muscle, whereas cardiac troponin is as high as 6 milligram per gram and cardiac troponin T is as high as 10.8 milligram per gram. So that means they can be a much more sensitive marker than others because they are present in more volume in the cardiac muscles. Therefore, this is what the entire scenario is changed. With the advent of high sensitive troponin I, the management and diagnostic protocol of ACS is changed. In the year 2007, that is, the recommendation was initially to do a troponin and to repeat after 6 hours, because from 0 to 6 hours, there is no significant difference may be noted. So the repeat testing was a 6 hours difference. By 2011, it has reduced to every 2 hourly. So the recommendation was to do cardiac troponin. The already high sensitive troponin has come in the market. So to detect the high sensitive troponin on 0 hours and then 3 hours. But now it has been even more dependent on troponins now. It is recommended to do every hourly, because every hourly change of troponin also can be a diagnostic marker of an ACS. So this is what our cardiac marker timings, as I have already discussed. See this one. You can see that then in acute MI, this is the portion after 4 hours, it has got a steep rise in the blood. Okay. But thus the rising has started from 0 to 4 hours. So since your instrument can detect in this level, the cutoff level is very high, so you cannot detect a change in 0 to 4 hours. In high sensitive troponin I, that is the thing, that our system, we have made more sensitive systems to detect this uprise from 0 hours to 4 hours. So therefore, every hourly rise of high sensitive troponin I can be detected. So this is no different molecule. It is troponin I only. But we detect it with a higher sensitivity of system. That is why it is termed HS troponin I. So this HS troponin I is actually did miracle in the treatment of cardiac patients because it enhanced the time of treatment to as low as 0 hours. So when the patient immediately entered the cardiac emergency with chest pain, we can start detecting troponin I with every hourly. And in point of care testing, this is much more possible. So this is a clinical case where you can see Mr. X with 48 years and all features of risk factors like smoker, overweight, diabetic, etc. The 2 hours ago, there was an episode which lasted for 20 minutes, but you see the ECG is not showing any difference as well. So you need to repeat on the ECGs. Here, the only answer with your HS troponin I, which is showing high 200 nanogram per liter. So the patient started treatment immediately. So this is the advantage of having a high sensitive troponin I in detection in a clinical emergency department. There are heart failure biomarkers also, as I already have talked about it. So the heart failure things we divide into two parts. One is chronic heart failure, which progresses chronically, and acute heart failure, which can be immediately, and this is life-threatening, where a heart failure fails immediately and all the signs and symptoms comes. Heart failure means you know what is heart failure. The heart unable to pump. So what happens? Heart gets enlarged, and there is a pumping failure, and so backflow pressure comes up. As we have already discussed these things, I'm not going to in a detail. But in heart failure, there are two management differences. In chronic heart failure, that gradually worsen the situations, so we have time. But in acute heart failure, it always comes an emergency, so we actually don't have enough time to react on. These are the symptoms. Chronic heart failure is a very poor at the early stage, but insidiously develops, and initially at the dyspnea with efforts, and more, even at rest, they can develop dyspnea. But in acute heart failure, the symptoms are shortness of breath or dyspnea and can rapidly be critical. It can immediately lead to rapid heartbeat, sweat, agitation, and patient may go unconscious. So this acute heart failure is an emergency where you need to treat this earliest. This is what earlier methods can do well. Clinical symptoms with shortness of breath, tachycardia, and all other things. With ECG, in heart failure, ECG sometimes being very specific, majority they are very non-specific. X-ray also can give you some sign of the backflowing pressures, edema, pulmonary edema, and all these things, but still not specific. But only two things have been specific. One is a biomarker, NT-proBNP, as we told about. And second, the gold standard is echocardiogram. Again, I am saying it is as low as 1% of the treatment case. Echocardiography is available in the emergency department. So, majority again you have to depend on your biomarker, that is NT-proBNP. So, as you know, what is NT-proBNP does? Whenever there is a hypotension, the renin-angiotensin aldosterone activity increases, so that sodium and water retention increases the blood pressure. But in severe cases, hypertension, what happens? You need a vasodilatation and natriuresis to get it down. So the same thing happens in case of natriuretic peptides, as I have already discussed. I am not discussing it here. So the NT-proBNP and BNP section comes. The BNP is actually the active molecule. With one NT-proBNP, one BNP ECG. So therefore, measuring BNP and NT-proBNP is more or less the similar. This is what important. This is guideline. Initially, up to 2012, the guideline was in suspected case of heart failure, first do a chest X-ray, then you do NT-proBNP, then echocardiography, step by step. Now, all are done at first, immediately. The ECG, chest X-ray, and NT-proBNP immediately, because the diagnostic capacity of NT-proBNP has become very high. So, therefore, the natriuretic peptide applications are for three cases: for diagnostic, for prognostic, as well as for guided therapy. So if the diagnosis of heart failure and also prognosis, looking at the amount of NT-proBNP, you can have a prognosis whether this acute heart failure can be life-threatening or can we get some time to revive the patient. And also it helps to guide the therapy, because with the start of therapy, we gradually, step by step, use natriuretic peptide application so that we can guide it whether our treatment is going well or not. So therefore, in chronic heart failure, it is used for early diagnosis, and in acute heart failure, it is the very important thing to differentiate between the shortness of breath between a heart failure and a pulmonary edema or pulmonary-related dyspnea. So, these are the protocols. Now you see, in suspected chronic setting, in less than 75 years, more than 125 is a definite of diagnosing a patient of heart failure. When the age is more than 75 years, as high as 450 picogram per ml can be a cutoff to diagnose if it's a heart failure. And therefore, there are certain drugs also there for which, this is the slide I have given. This is a very practical slide, that sometimes the Entresto is a drug which is very much used nowadays for heart failure treatment. So now what happens in giving Entresto, and if you're using BNP as a marker, it will be a misleading one, because this particular drug is actually holds the degradation of BNP. So what happens? If we use the drug, more and more BNP will be accumulated, and because of the action of BNP, heart failure will be subsided. Therefore, if you try to diagnose on the basis of BNP, he will be never. Because if the patient is treated with the drug even, the BNP will never stop rising. So therefore, that is a major loophole, or there is a major drawback of using BNP as the marker. So we always use proBNP, because nowadays these medications give a false guide on that. So these are NT-proBNP versus BNP. As I have already told it, NT-proBNP is a much stable one. BNP has got a very short life of 16 to 20 minutes. So for diagnosis, you always take out NT-proBNP instead of BNP. So therefore, I conclude all the things about cardiac biomarker. I have already given it in the last slide also, that there are the markers of different purpose. For prognosis, we use all these markers. For diagnosis, we use MI diagnosis, we use these markers. And for heart failure diagnosis, we use these markers. So as a whole, all including this concludes the cardiac biomarkers in a nutshell. Hope you liked all these slides, and you can question if you have any question on that. And also, I would be happy to answer you. And at the same time, thank you for listening, and I would expect that people will subscribe more and more, and we'll get moral support for that if you get more subscribers. Thank you.